Hi, I'm John Esdale, the Scientific Director of the Arthritis Research Center of Canada. The purpose of this video is to show you a standardized knee exam that has been developed by Dr. Yolanda Sibert for research purposes. When Dr. Sibert first started to think about how to evaluate osteoarthritis of the knee and how to detect it earlier, a huge gap was the lack of a standardized way of examining the knee. What follows is a visual demonstration of the standardized knee exam developed by Dr. Sibert and her colleagues that has made such a difference to how we can detect this disease early on. The Room Tube project started almost a decade ago. A scientist, Yolanda Sibert, started thinking about early osteoarthritis of the knee, how difficult it would be to diagnose it, and started her first project really was to standardize the knee exam.
My focus is really on identifying osteoarthritis at an early stage. And I came to this problem when I was recruiting for a study using standard criteria, and they included X-ray. And I found when I was recruiting patients for that study that the majority of the patients didn't qualify for the study because they had normal X-rays, but clinically they had typical symptoms of osteoarthritis. So I realized that we're missing a huge segment of the population with pain and osteoarthritis that is so early that it's just not captured. So that led me into the research that I'm doing on early osteoarthritis to help diagnose it earlier, predict progression of disease, and predict those who are at high risk of progressing so that eventually we can intervene with appropriate treatments.
Well, osteoarthritis is extremely common. There are about 100 different types of arthritis, but the most common type is osteoarthritis or wear and tear arthritis. And osteoarthritis affects in the order of 10% of the population.
Well, there are a number of reasons why people get osteoarthritis. There are certain risk factors that we do know about. Genetics for sure plays a role. People who have injured their knee are at risk of developing osteoarthritis down the road. And people who are overweight are also more likely to get it. Women are more likely to get it than men.
Women get osteoarthritis about twice as commonly. There's not much we can do about our gender, so that's a difficult one to alter. But the one that's modifiable is obesity. We know that, for instance, if you looked around a room and compared the people in the top third of weight to those with the bottom third of weight, those in the top third are about 10 times more likely to get osteoarthritis. Quite a staggering number, so that being overweight, perhaps not a lot overweight, is a major risk factor for osteoarthritis of the knee.
Primary care doctors and rheumatologists alike see a lot of knee problems, and it's very important for medical students to learn a systematic, appropriate approach to dealing with diagnosing knee problems.
The reason for standardizing an examination technique like the knee is that if one physician examines a person and says, I think there's fluid in the knee, and another physician examines the same person at the same time and says there isn't, then what's correct?
People with osteoarthritis oftentimes will benefit from the care of a team of health professionals, and that may include family physicians, rheumatologists, physiotherapists, and other health professionals. One of the challenges in providing the best care is to be able to communicate in a way that everybody understands each other. So having these standardized tests will allow health professionals who are working with the same patient with knee pain and knee osteoarthritis to be able to communicate each other in an efficient manner. So the standardized tests can definitely help to improve the care for people with osteoarthritis in the knees.
So the first step in assessing people is how do we actually assess clinically the knee in detail. So what I realized is that there's many techniques out there, but they haven't really been standardized. And so that's where we set out to standardize the knee examinations. And that really helps that to ensure that findings when we examine the knee are reliable. So we looked at all the tests that are out there and all the different maneuvers that have been done to try and assess those tests. And for this particular video, in terms of teaching medical students and family practitioners, we focused on the clinical exams that are most useful, that need to be done when you suspect osteoarthritis or to assess the joint completely. From our research, we've shown that a few simple questions and 3 knee exam tests are useful to identify osteoarthritis, especially patients with early disease. The 4 questions we ask are: have you ever had discomfort or pain in the knee on most days of the month? Have you had any discomfort or pain in the past year? Is it worse with activity? Is it improved with rest? And the 3 knee exam tests are Effusion, Gait, and Flexion Contracture. There are 2 tests that we do to detect swelling. Because they detect different amounts of fluid, we use them in conjunction with one another. With this test, we sweep away the fluid from the medial side of the knee and then sweep it back in from the lateral side, looking for a bulge to appear medially, which indicates a joint effusion. And in this case, there's a bulge right here. That's visible right there. So a positive bulge test tells us that there is a joint effusion. With this test, we can detect a larger amount of knee swelling. I push the fluid into the knee joint with the left hand, and then with the right hand, push down on the patella, looking for a tapping sensation as the patella hits the femur underneath, which indicates a positive patellar tap. And in this case, I don't get that at all because there is no knee swelling, so the patellar tap is negative. Also in the standing position, we can assess the gait. We ask the patient to walk back and forth a few times. Can I get you to walk a few steps at your normal speed? And turn around and come back this way. And in the assessment of gait, we look for any limp or abnormality of the affected knee in terms of the stance or swing phase of the gait. And we grade it as normal or abnormal. And in this case, we can see that there's a mild limp on the left side with incomplete extension of the knee. Another test we do while the patient is still supine is to check for flexion contracture. For this test, we can just simply inspect by trying to extend the leg as fully as possible. So you stabilize the thigh and push up on the leg with the other hand to see if you can straighten out the knee more fully. And in this case, there's a flexion contracture present, as I cannot straighten this leg anymore. I also know it because there's a gap between the examination table and the knee. This is a test for alignment by inspection. With this test, you have the patient stand facing the examiner, feet approximately shoulder width apart, with weight borne equally on both legs. With this test, you look at the alignment of the femur in relation to the tibia, looking for an angulation at the knee in the varus or valgus direction, varus being bow-legged, valgus being knock-kneed. In this case, there's varus deformity. With this test, a slight degree of valgus, up to 5 degrees, is considered normal. In the sitting position, we can assess muscle strength. And one of the tests I do is to look for an extension leg. I ask the patient to extend the knee as much as possible. Can you straighten out your leg? And then passively, I further extend the knee if possible. And if I can further extend the knee, it means that there's an extension lag present, which means the knee is just lagging and can't be fully extended by the patient actively. And that indicates that there's weakness of the quadriceps muscles. The other test that we do sitting is to assess quadriceps and hamstring strength directly. So for this test, I put my hand above the ankle anteriorly to test the quadriceps strength, and I ask the patient to push out against me as hard as they can without moving the joint, and that is normal strength. And then I'll ask them to push in against the examining table while my hand is placed posteriorly. Pull as hard as they can. There's some weakness of the hamstrings in this case. Okay, for quadriceps atrophy, we assess the bulk and size of the quadriceps muscle, and particularly paying attention to the medial side. And in this case, you can see the concavity on the medial side indicating loss of quadriceps muscle. Normally this would be bulky here, particularly medially. And it helps comparing to the other side too sometimes, as one side may be atrophied and the other may be normal. In this case, there's atrophy on both sides, and it's graded as either mild or severe. In this case, we have severe atrophy. Okay, another important test is to test for tenderness in and around the knee joint. We put the knee in a 90-degree flexion. Knee-specific tenderness related to the joint itself is testing for medial tibiofemoral joint line tenderness, which is tenderness anywhere along here along the joint line, or lateral tibiofemoral tenderness along the lateral tibiofemoral joint line. Extra-articular tenderness relates to the patellar tendon, so a test from the lower pole of the patella along the patellar tendon for any tenderness, and the anserine bursa, which is medially 1 to 2 centimeters below the joint line. We can also check for bony swelling. With this test, we place the knee at a 60 to 90 degree angle and look for bony swelling on the inside of the medial tibia and lateral tibia. And we actually inspect and palpate for bony swelling. And there is some bony swelling here medially. This is an important test to do because finding a bone spur is one of the key findings of osteoarthritis. Another test that is important in osteoarthritis is to assess for crepitus, which is the grinding sensation and crackling sensation that we feel when we move the joint through its range of motion. I put the palpating hand over the knee, while the other hand moves the knee joint through a range of 30 to 90 degrees flexion. And with the palpating hand, I feel for any grinding or cracking. And a single click or crack is not considered crepitus. And there's a tiny bit of grinding in the knee. Another way to test for pain from the knee joint is to assess end-of-range stress pain. With this, we bend the knee as far as it goes comfortably, and then apply gentle pressure at the end of range and look for a pain response and ask whether it's painful. Another test we can do to assess the patient's knee while the patient is lying is to look for the degree of range of motion in flexion. So I'll get the patient to bend up the knee as far as it goes or as far as it's comfortable with the foot straight on the examination table. The most reliable way to assess flexion range of motion is to use a goniometer, but if no goniometer is available, visual estimation can be used. And I look for the degree of flexion just by eyeballing whether it's normal or abnormal. And in this case, flexion is not normal, because normally the foot could come much closer to the thigh. Flexion and flexion contracture are often abnormal in osteoarthritis, and hyperextension is a way of assessing joint hypermobility and may relate to osteoarthritis. To assess hyperextension, we stabilize the femur while pulling up on the leg to see whether we can extend the leg beyond normal. So there's a hyperextension on the right leg, and it's often symmetrical, so we can check on the other side, and it's present there too. Often medial and lateral instability is tested at full knee extension and 30 degrees of knee flexion. However, the test at 30 degrees flexion is not reliable for osteoarthritis. I am testing for instability at 0 degrees with the ankle under my arm and the thumb on the joint line. Now, to test for medial instability, which really tests the integrity of the medial collateral ligament, I apply a valgus stress and look for a gap over the medial joint line. To test for lateral collateral ligament stability, I apply a varus stress and look for a gap over the lateral joint line. To test for anterior and posterior instability, I put the leg in 60 degrees of flexion, and I make sure that the patient's knee is relaxed. You can tell when the knee is relaxed when the hamstrings are not tight in the back of the knee. And you can only do this test with relaxed hamstrings. So the anterior cruciate ligament integrity is tested with the anterior drawer test, where you pull the tibia forward and look for movement of the tibia in relation to the femur. And you can see that there's actually forward movement. So the anterior drawer test is positive. Posterior drawer test tests the posterior cruciate ligament integrity, where you push the tibia back in relation to the femur and watch for movement, and there is none. The other way we can assess for posterior cruciate ligament integrity is to put both legs up to 90 degrees, this one too. So for the posterior sag test, we place the knees at 90 degrees and look for posterior sagging of the tibia in relation to the femur. And we can compare sides, and there's no posterior sag here.
The work that Yolanda Sibert and others here and across Canada have done suggests that, in fact, the diagnosis of knee complaints is very poorly done. The medical students were never trained. They become family physicians who haven't had the training and therefore are uncomfortable making this sort of diagnosis.
Well, I think the teaching program is really going to help physicians have a confident, systematic approach to examining the knees. And I think it will make them more confident in dealing with their patients and reaching a diagnosis, making a referral if it's deemed warranted. But I think it will translate to the most important thing, which is better, more optimal patient care.
The standardized tests are really useful for complete assessment of the knee. So they could be used by any trainees, such as medical students, physiotherapy students, or other healthcare professionals, to learn how to fully assess the knee and to do so in a standardized and a reliable way. So hopefully this will benefit medical students across Canada and beyond.
I think the big challenges in diagnosing osteoarthritis is really this attempt to get the word out that for so long it was believed nothing can be done for osteoarthritis. It's now clear that if you pick it up early, work by Dr. Carlo Mara at the University of British Columbia has shown that when you diagnose it early and intervene, you can really make a difference to people's outcome. So this is key. Now that there's options, the need for early diagnosis becomes much more pressing. And in fact, it's hard to think of a condition where early diagnosis doesn't help, whether it be a cancer or heart disease or kidney disease or anything. Generally, the earlier you identify the problem, the easier it is to treat and the easier it is to prevent long-term adverse problems. Thank you for watching the video. I hope it's going to help as much as we hope it helps you. If you can examine the knee better, it's going to make a huge difference to people with arthritis everywhere in the world. Congratulations on doing your work and have fun using these techniques. If you need the latest information, go to our website, arthritisresearch.ca.